wait for questions at the end of the entire session? How do you?
Should we have the discussion after all the three? Yeah, okay, yeah. We take the discussion after all your talks, yeah? Sì, cominciamo alle 9 e fa la discussione dopo
Allora abbiamo Festa c'è, Doris c'è là, vediamo.
I think this mic is on if you want to. If you want this mic, and
no,
then
it's-
just
have
give
it.
him a second.
Wir haben überhaupt keine Schilder.
Okay, dann
Es sind alle anderen Schilder da, nur nicht unsere, aber es macht dann nichts.
wo sollen wir sitzen?
Wir sitzen da, wir können das alles gescheit schauen. Okay. Ja. Das war kein Problem.
Aber das ist spannend, weil
Buongiorno, good morning. May I introduce myself? Most of the people I already know for decades, let's say. My name is Doris Enger. I'm from Vienna, and together with my co-chair, which I would like to introduce, which is Ruth Haing from Leuven in Belgium, we are happy to chair the first session in the morning. Due to the fact that we started a little bit late, we had decided that we will have a common discussion after all the three talks. And let's start with the first speaker, that's Anitra Rumpf. She's an adult cardiologist. She's from Stanford University. She's part of the Adult Congenital Heart Program. And the title of her talk is From Surviving to Thriving, Living Well with Adult Congenital Heart Disease. Anitra, please stop.
Thank you very much for this invitation. Thank you to Professor Squarcia, Dr. Sanders, and Dr. Valenti, my mentor, who, along with Dr. Sanders, have mentored me over the years. I'm very grateful for this opportunity. So it's my pleasure today to talk to you about adult congenital heart disease, and you'll see in a moment, or hopefully by the end of the talk, that we are excited to move from, hopefully from surviving to thriving. The objectives of my talk kind of stem from some of the questions that I was asked by Dr. Sanders. How are our congenital patients doing in adulthood? What are their hemodynamic and neurocognitive outcomes? How can we improve outcomes in our field? And can we, I added this one, can we move from a compartmentalized view of congenital heart disease as being dichotomous as either pediatrics or adult to more of a health span or lifespan approach? I think we can. So how many patients are living with congenital heart disease today? Globally, these estimates are, suggest that the total number of children plus adults range around 10 million. And as you all know from this paper from Ariane Morelli, there are a number of factors that contribute to this, including prevalence, access to care, detection, which has improved over time with universal screening, for example. So many things kind of factor into this, along with the improved surgical and medical techniques that have occurred to bring these folks to adulthood. That's the reason why I have a job. So this graph shows, you can see that the increasing prevalence of all congenital heart disease, as well in A, as well as severe congenital heart disease in B, have been increasing over time. And I'll just take a moment to use some terminology here. Many of the older papers use the classification of mild, moderate, and severe forms of congenital heart disease, which was defined in the Bethesda conference originally. Since then, many of our ACC-AHA as well as ESC guidelines have moved towards a simple, moderate, complex, but the general schema is the same in terms of dividing these groups up. So I like this graph because it also kind of demonstrates where we've been. This graph shows on the left side of your screen that between 1987 and 1988, there was a bimodal distribution. So on the left of the graph, the severest forms of CHD died at age 2. So you can see I've put an arrow there right on the left side of the graph to kind of indicate there were 2 peaks where we were suffering originally. If you compare that to the right side of the graph, taken data, cumulative data between 2004 and 2005, the curve resembles that of a normal distribution where the mean age of death for the severest form of CHD moves from age 2 to age 23. So we're shifting that burden to adulthood, which is kind of a good problem to have in a way. So I like this graph because it sort of visually shows that. Even the moderate to complex CHD are living longer. So looking at this Canadian database from the Toronto General database, where they looked at about 12,000 adults followed between 1980 and 2009, they selected moderate and severe groups of CHD such as Eisenmenger syndrome, unrepaired cyanotic congenital heart defects, atrial switch operation, CCTGA, Fontan, and tetralogy. And this time span shows that the evolution in the age distribution of the patients. You can see the emergence of the age groups of 51 to 60 or greater than 60, as shown in that red arrow in 2009, the emergence of this category. So again, good problem to have. So looking at overall curves, how are we doing? You can see in the green that the simple congenital heart defects that make it to adulthood have similar survival curves to the general population. But that survival curve is curtailed as we go into blue and orange, which represent the moderate and complex, or we should say, in the prior terminology, the moderate to severe defects that are making it. So we still have work to do, as evidenced by this graph. And so what are some of the hemodynamic consequences of patients that make it to adulthood? Certainly, to this very well-seasoned group, we all know that shifting burden in adulthood lends itself to admissions for heart failure, arrhythmias, pulmonary hypertension, thromboembolic events, endocarditis, sudden cardiac death, comorbid conditions, and the need for reintervention or surgery. With these hemodynamic lesions, of course, you're not surprised that healthcare utilization is up, right, in this group. And so this graph taken from the Quebec database shows that those with the severest forms of CHD are twice as likely to be hospitalized in the ICU, and 30% more likely to be hospitalized overall, and about 10% more likely to visit the emergency room. So it's a bit sobering that we're shifting this burden to adulthood, but through that, at the moment, we're using more healthcare resources. So something to kind of keep in mind as we're thinking about this lifespan or health span approach. Health span, of course, just to define that term, as being the time when patients are generally well. And so likely those periods of time that are dotted in hospitalizations really put a decrement in that quality of life. So with increasing age of the ACHD population, the risk of acquired heart disease also rises. Atherosclerotic cardiovascular disease, or ASCVD, comprises a group of conditions that involve the buildup of plaque or atherosclerosis in the arteries. We often will say there's disease below the neck, there's likely to be disease above the neck. Just sort of general themes as a cardiovascular specialist. And so, as you can see here, this can involve atherosclerosis of the brain, which can lead to TIA and strokes, atherosclerosis of the heart arteries, which can lead to myocardial infarction, and atherosclerosis of the peripheral vasculature, which can lead to symptoms of claudication or limb ischemia. When compared with the general population of similar ages, and here's something that may be a little shocking to this group, patients with adult congenital heart disease show more pronounced risk factors for the development of ASCVD, or cardiovascular risk. So not only is it more pronounced, it's earlier onset, and a higher burden exists even among the simplest forms of disease. So just take a minute to absorb that. So wait a second, I thought we just went over that survival curve, which looked at the simplest forms as doing nearly as well as the general population. And now we see that this emergence of a different signal that could serve to drag down that survival potentially in adulthood. So keep your ears peeled for further interventions of how we can improve this and thrive later in life. So So some risk factors, not only does acquired heart disease represent the leading cause of death in the global general population, but also a growing concern for ACHD, as I mentioned. In these patients, the burden of morbidity and mortality is shifted, of course, from congenital sequelae to the acquired atherosclerotic events. So on the left of the screen, you can see some risk factors for ASCVD development, as well as the presence of psychiatric disorders. Note that the increasing prevalence above the background population for hypertension, diabetes, and psychologic disorders in this population. So I'm just outlining that here to show that these three are increasing over time, so something to pay attention to. In addition to the finding of ASCVD and psychiatric disorders being on the rise in adult congenital heart disease, neurodevelopmental effects are also present. I, of course, don't need to tell this very seasoned group that about the presence of neurodevelopmental effects, but perhaps we can shed some light on that these don't go away even with intervention, and detection early on, and that's something to really keep in mind. So adults with CHD consistently demonstrate measurable neurocognitive deficits across various domains. I have put a box around the executive functioning of our patients, which includes intellectual function, academic success, speech and language skills, as well as motor skills. These deficits can impact daily life activities, such as educational attainment, employment status, and overall quality of life. Dr. Steiner will be touching on some of the psychiatric outcomes and mental health in her talk. These factors affect the factors that go into the early brain development, as this group knows, include genetic, perinatal, surgical, and perioperative growth and development. This leads to abnormal brain development and adverse neurodevelopmental outcomes, which contribute to adverse psychosocial and physical outcomes, all of which lead to a poorer health and a health-related quality of life. So starting in childhood, patients experience neurological impairment, and this worsens with the severity of the cardiac defect. Lower socioeconomic status, unfortunately, and parental education are associated with worse neurocognitive outcomes in individuals with CHD. So because patients are living longer, however, these neurodevelopmental deficits in childhood have a greater window of exposure by the time they reach adulthood. Thus, in the health span model again, neurodevelopmental sequelae in children with CHD evolve during adulthood into cognitive decline and likely dementia as these patients age. So despite a rich literature in childhood for neurodevelopmental outcomes in CHD, few studies have addressed this translation into adulthood. And it's really something that we have to keep in mind in our transition clinic, how we deliver information to our adult patients, how we expect adherence and understanding of healthcare plans, making advanced care planning, which is all stuff that'll be discovered later. But if we are dealing with this baseline of sort of a snowball effect of these neurodevelopmental outcomes that have this longer exposure time, over time, this is going to impact this in a very significant way. So I like this graph, or this schematic, because it's kind of showing there's various mediating pathways. Vascular risk factors get put on top of that. Arrhythmias get put on top of that. Other epiphenomena are there. And vascular disease begets worse cognitive outcomes, which begets more vascular disease. So you can see the cycle of what we're dealing with in adulthood. And I like this is because, again, thinking of our health span, lifelong neurocognitive considerations must be considered in CHD. So when we take this lifespan approach, we can see how these early factors persist to every facet of life. And spoiler alert again, Dr. Steiner will be talking about resilience and other social determinants of healthcare, and Dr. Gauthier will be discussing physical activity as part of health behaviors. So this whole session is sort of dedicated to how do we usher these patients in an anticipatory guidance type of way. And that's, just to give a plug to pediatricians, because my background is pediatrics and internal medicine, that type of anticipatory guidance is missing from the adult model of care. And it's something that we, all of us adult congenital folks, really seek to bring to help our patients know, hey, here's what the next decade looks like. I mean, imagine if you went to the pediatrician and you were staring at your pediatrician at 1 year of age and say, well, have a nice life. They don't do that, right? They tell you what's coming up in the next year, 2 years, what skills you can anticipate. We sort of dropped them off on the doorstep of adulthood saying, okay, have a nice life. But we really should be helping them and consistently understanding and helping them understand what's coming up next. So anticipatory guidance, I'm a big fan. So with these neurodevelopmental effects, this can affect the type of job that is attained. So looking at this UK cohort of 210 Fontan patients, some patients held professional occupations, but there were smaller numbers of associate professional and technical occupations. A greater number were employed in elementary type jobs such as cleaning or warehouse workers. Overall, 43% were deemed economically inactive, which included, of course, 25% who were in school. So the fact that there are smaller numbers potentially may stem from some of these snowballed neurodevelopmental effects, the seeds of which were sown in childhood and only worsened over time as we sort of passed them on. And we should continue to care about this because those employed in part or full-time work tend to have higher quality of life scores and life satisfaction scores. And we know this is good for mental health, a sense of well-being, a sense of I belong in society. After all, that's what we're here for, I always tell my patients, if I'm doing my job, you won't need me, or you'll need me less. So I think it really bears importance here. So this is part of my plug is now that survival to adulthood is largely achieved for all types of CHD, how can we allow our ACHD patients to thrive? So let's start with the acquired risk factors that lead to ASCVD risk and see how now in the right, in purple, these are the strategies for risk modification and mitigation. With respect to hypertension, diabetes, psych disorders, dyslipidemia, obesity, and smoking. So with respect to each of these risk factors, a recent paper suggests that screening for hypertension at all visits, as well as ambulatory blood pressure readings for those who are at risk, possibly exercise-induced hypertension that can be brought out on exercise testing, may bring out some subclinical hypertension that can worsen us later as something to be aware of, rather than, so some of these things that we can pick up perhaps in adolescence or late childhood may help us then in the future. And similarly with diabetes, our population, at least in the United States, we're suffering the epidemic of obesity. And with that sometimes is glucose intolerance. And so we are trying to encourage performing a hemoglobin A1C screening or fasting plasma glucose screening. And at Stanford, for our most severe forms of CHD, which is the single ventricles, Fontan patients, we start that screening in adolescence on a yearly basis. In addition, with respect to obesity and inactivity, we start that counseling early on in adolescence and are quick to bring on our cardiac nutritionists, especially for those who are at risk, and really starting that process earlier on in conjunction with the pediatrician, in conjunction with the pediatric cardiologist, are some of the most important things we can do, that work that I do in our transition clinic. Obviously, with smoking, smoking cessation programs are key. And I'll just say a word about the Stanford approach to psychiatric disease, because my colleague will be addressing this more. But for patients who are less than 18, we have a program where we are addressing this earlier on in kids. And I run the fellowship program, so I get many pediatric cardiology fellows as well as adult cardiology fellows. And you know, people have made offhanded comments like, "Oh, I'm glad I don't have to deal with those adults. You know, they may have some psych disease." And then I kindly smile at them and say, they may be there, those deficits may be there in a younger age. We just may not be asking the right questions. And so Ollie's branch is a way to support kids as well as their families and actually our healthcare providers, and provides a really nice framework for patients to be able to get access to counseling through telehealth and other support services to survive this journey, lifelong journey of congenital heart disease. For our adult patients, we offer at Stanford cardiac behavioral health, because we know that it's nerve-wracking to go through a procedure, for example, and you may need some extra support when doing that. Also of utmost importance is having a social worker to help assist with services that may be available in the community. At Stanford, we also in the pediatric clinics have a multidisciplinary team, as many of you all do, for cardiac-related neurodevelopmental issues that can creep up. And so I love this guidelines that have come out recently to kind of talk about, okay, looking at each patient. Are they in risk category 1 in childhood? Have they had a bypass run? Well, most times, if we're taking care of them, yes. Risk category 2, a history of chronic cyanosis. Think of your interstage children, for example, going down the single ventricle pathway. If those are yes, those are high-risk patients that we need to make early referrals for. If not, then we kind of move on to risk category 3. Is there a history of intervention or repeat surgery that occurs in the lifespan of this patient when they're still in childhood? If that answer is yes, do they have one or more of these risk factors for adverse neurodevelopmental outcomes? If yes, we make another referral. The key that I would also urge our adult practitioners to say is, we're not done here. Just because you check the box and say everything is okay doesn't mean we're done and finished and, again, dropped off on the adult doorstep. We as adult congenital practitioners must continue to screen and aid in this process. So one of the things I like is also as part of my job is that I get to participate in the single ventricle clinic, in which we have a multidisciplinary approach, as many of you all have in your clinics, where we have both pediatric and adult cardiologists, hepatologists, nutritionists, endocrinologists, as well as routine neuropsych testing for our single ventricle patients. And then we also have an education specialist and career counselor that will help these parents advocate for additional plans that can be helped to bolster their success in school, as well as social work and counseling services. A really comprehensive program that I'm proud to be part of and wish that I could duplicate for every type of congenital heart disease. So how do we deal with the healthcare utilization? Well, turns out teamwork and guidelines actually work. I love this graph because what it shows here is the original Bethesda sort of guidelines, before guidelines actually, but sort of recommendations that started to percolate. And you can see that there's been, after that introduction, there was an increase in referrals to adult congenital or specialized congenital centers, I'll say, which of course decreased mortality. So it turns out when we do things in a more codified, unified way, that we can get better outcomes. And I would also add for a plug for our advanced care, I don't what they're called in Europe, but certainly advanced practice providers that are physician extenders and can see your patients on a regular basis. The more we can, sometimes we have sick enough patients that we'll see them twice a month, just to keep them out of the hospital, right, for heart failure management. So a big plug for that. So in summary, we can celebrate that we have increased numbers of moderate and severe types of CHD that are surviving into adulthood. Yay. I definitely end on that positive note. We can also sow the seeds for health span by screening and treating ASCVD risk factors, since some of these are beginning in childhood. We can identify and continually screen and treat throughout the health span neurodevelopmental deficits to support our patients so they can have an increased quality of life. And we can reduce hospitalizations by applying team-based care to help keep our patients out of the hospital. Adherence to guidelines is key with that. And lastly, we can identify and support psychiatric disorders by acknowledging them in childhood. And I'll leave these departing thoughts of things that I wonder about to our discussion. And I want to say thank you from the Adult Congenital Program at Stanford, and thank you for this opportunity.
Thank you very much, Dr. Romp, for this really great presentation. I think you succeeded us to believe that we can celebrate the development in CHD for the last 50 years and that we need a multidisciplinary approach to face all the challenges. Thank you very much. And with this, I come to the next speaker. So as we face all the challenges, we need to take care about our patients living the best they can. And I'm happy to introduce Dr. Steiner. She's from Seattle, an adult congenital cardiologist, and her research field is on palliative care, resilience, and well-being. And so she's really the good expert to talk about living my best life, social and lifestyle issues for adults with adult congenital heart disease. Please, Dr. Steiner.
No, he can, or Steve can. Do we know? So this was just from here.
sorry for the delay due to technical problems. It had worked before, and we are waiting for the technician. Sorry.
I just unplugged that and put it into that Alessandro's. And I didn't unplug that computer. Yeah. Yeah, let's just add it to that.
It worked. It worked. It worked already. No. There must be a problem